Benign breast diseases comprises a number of conditions, mastalgia or breast pain being the commonest presentation, benign lumps in the breast, nipple discharge, disorders of the nipple and areola, inflammatory conditions, lactational and non-lactational mastitis, congenital and growth anomalies due to embryological defects, and lastly, diseases of the male breast in the form of enlargement called gynecomastia. Today, we will be talking in detail about clinical manifestation and treatment of benign lumps, namely fibroadenoma and phyllodes tumor. Majority of the benign lumps fall under the category of ANDI. This will comprise fibroadenoma, cyst, cyclical nodularity, sclerosing adenosis. Other conditions leading to lumps in the breast of benign nature include inflammatory conditions due to fat necrosis, chronic abscesses, benign tumors like phyllodes tumor, lipoma, which is very rare in the breast, which is quite interesting considering the amount of adipose tissue present in the mammary gland. Sometimes duct papilloma within the major milk ducts. Lesions of the nipple and areola in the form of leiomyoma, retention cyst. Lesions of the skin covering the mammary gland may present as sebaceous or epidermoid cyst, and infection of the apocrine glands known as hidradenitis suppurativa. It is interesting to note that breast itself is a modified apocrine gland. Sometimes normal structures within the breast or chest wall may mimic a lump, such as a prominent or conspicuous rib or intramammary lymph node. Different manifestation of ANDI or aberration of normal development and involution can present in three phases of mammary gland: development, maturation and involution. Beginning age 15 till age 25, when mammary gland is undergoing development, lobular development may become pronounced and present as fibroadenoma, which can become giant, that is more than 5 centimeter in size, resulting in giant fibroadenoma. Similarly, stromal hypertrophy may become conspicuous and present in a young girl as adolescent hypertrophy. Nipple may fail to evert and a young girl may present as nipple inversion. In the mature age group, beginning age 25 till age 40, we have cyclical changes of menstruation which may become conspicuous, presenting as cyclical mastalgia with or without nodularity. Similarly, hyperplasia of pregnancy may become prominent and lead to blood discharge from the nipple. In the last phase of mammary gland natural history of involution, beginning age 35, progressing up to menopause, we have involution of the lobule, which may result in cyst formation, which can be microcyst or macrocyst. Involution of the ductal system may lead to its dilatation, presenting as ductectasia. Similarly, epithelial turnover may become abnormal and result in hyperplastic epithelium of the duct or lobule, which can progress into atypia of the ducts or lobule, known as atypical ductal hyperplasia or atypical lobular hyperplasia. Among the benign lumps, fibroadenoma is the commonest type of discrete lump in the mammary gland, presenting mostly in young girls from age 15 till age 25. WHO considers it as a discrete benign tumor with mixed connective tissue and epithelial proliferation. However, some experts consider it as part of ANDI. Median age of presentation is 30, ranging from 15 to 35. Clinically, a lady presents with a well-defined discrete lump which may be rubbery in consistency, usually non-tender. The distribution of fibroadenoma in the mammary gland in different quadrants is presented on this slide. The commonest site being the outer upper quadrant. And you know why? Because 50% of the ductolobular tissue is located in the upper outer quadrant. Hence, all diseases of the mammary gland resulting from proliferation of the TDLU, terminal ductal lobular unit, involve upper outer quadrant. It is part of ANDI manifestation resulting from proliferation of the lobule, histologically comprising a mixture of epithelial proliferation as well as stromal proliferation. So, it is a mixed lesion of mesenchymal and epithelial origin. The natural history is such that majority of them are static, and some of them, about 10 to 30% of fibroadenoma, have the natural history of spontaneous regression if followed for a long time. Some fibroadenomas may involute around the time of menopause. During pregnancy, some fibroadenomas have a tendency to grow and become quite prominent under the influence of excessive estrogen and progesterone. Rarely, some girls may present with multiple fibroadenomata present in both the breasts, and this may be part of a rare genetic syndrome such as Maffucci syndrome, Carney syndrome or Cowden syndrome. It has been observed that in patients following transplant of the kidney or other organs who are kept on immunosuppression therapy with cyclosporin, fibroadenoma may become multiple and grow. Cigarette smoking has been found to be protective against fibroadenoma, but that does not mean you start smoking to prevent fibroadenoma in your breast. So, please, for God's sake, do not start smoking as a pretext for preventing fibroadenoma. At the genetic level, studies have revealed loss of BCL2, which is an anti-apoptotic gene, and its loss may result in proliferation of cells of the mesenchyme as well as the ductal epithelium, leading to fibroadenoma formation. It is a polyclonal condition as opposed to cancer, which is usually thought to be monoclonal in origin. Multiple fibroadenomata is a condition where more than 5 lesions are present in a breast. It can be present in about 15% of ladies, which could be bilateral in about 10% of all girls. The term giant fibroadenoma is applied to a fibroadenoma measuring 5 centimeter in its greatest dimension. This can be present either in the adolescent age group or near the menopause in the perimenopausal period. It is thought that multiple fibroadenomata has a slightly increased risk for development of cancer. The relative risk for developing cancer for ordinary fibroadenoma varies from 1.4 to 1.7. If it is a simple fibroadenoma, this risk can increase to about 3 times if there is an element of epithelial proliferation or hyperplasia seen under the microscope. If cancer develops in a fibroadenoma, it usually takes the form of a lobular carcinoma. Some studies have shown that both lobular as well as ductal carcinoma in situ can develop in long standing fibroadenoma. When a lady presents to you with a discrete lump in the breast, it is your duty to carry out triple assessment. Triple assessment comprises 3 components: detailed clinical evaluation in the form of history taking along with clinical breast examination. This is followed by appropriate imaging of the breast and pathological evaluation of the lesion by histology, taking core biopsy. Imaging of the mammary gland comprises an ultrasound. In a typical fibroadenoma, we describe the lesion as wider than taller. That is to say, when lady is lying supine on an examination ultrasound couch, this dimension is wider or more than the vertical dimension, and this is described as wider than taller. A classical fibroadenoma has a smooth margins with some lobulations and almost homogeneous echogenicity within the lesion. This is usually hypoechoic compared to the echogenicity of the surrounding breast parenchyma. A more advanced type of ultrasound assessment can be carried out using elastography, which ascertains the Young's modulus or elasticity of the lesion. Most fibroadenoma will be looking blue on elastography as opposed to orange color or hard lesion on elastography in a cancer case. Mammogram should be carried out if the lady is aged 30 and above, which may demonstrate again a well defined lesion in the breast. The pathological conformation of the lesion can be ascertained either by fine needle aspiration cytology, where a fine 23 gauge needle is inserted into the lump and cells are aspirated. The points in favor of FNAC for a young girl presenting with a benign lump are that it is fairly cheap and quick to perform, although one should be aware of the fact that it may have a high false negative, and it is suitable for well defined discrete lumps, but may be difficult to perform in an impalpable or deeply located lesion. On the other hand, a large needle core biopsy is mostly preferred by most breast experts. It is carried out by a 14 gauge core biopsy needle. 4 to 5 cores are taken to ascertain the exact histopathological nature of the disease. A simple fibroadenoma may be shown to reveal a mixture of fibrous stroma, usually with low cellularity and benign cytology of the epithelial tissue. There is a rare type of fibroadenoma known as complex fibroadenoma, where besides features of fibroadenoma, one finds a component of either sclerosing adenosis, epithelial calcification, papillary lesions or cyst formation. Some experts consider complex fibroadenoma to carry a higher risk of about relative risk of 3 for development of cancer. Question may arise whether biopsy is always necessary for a young girl. So, some breast experts are of the opinion that if a young girl presents with a discrete lump in the breast, which is classically categorized as benign by clinical evaluation, and there is no family history of breast or ovarian cancer, one may only carry out a detailed high resolution ultrasound scan and then reassure the lady without resorting to biopsy. Let us discuss the management of fibroadenoma. If a young girl presents with typical physical signs of a highly mobile breast mouse like lesion with no family history of breast or ovarian cancer, then we can just reassure the girl after an ultrasound evaluation. If fibroadenoma is less than 3 centimeter in size in young ladies below age 30 and lady is prepared to come for regular follow up, a medical treatment can be offered in the form of anti-estrogen tamoxifen in the dosage of 10 milligram per day for 2 to 3 months period, or ormeloxifene or sencroman in the dosage of 30 milligram daily for a period of again 3 months. These drugs have been found to regress fibroadenoma in 20 to 30% of cases. Some unique situation arises where patient presents with multiple lesions and there is a real dilemma as to operate, and if operate, how many of these lumps to be removed, because this may lead to multiple scars and damage of the major milk ducts or nerve supply to nipple and areola complex, something that should be avoided in young ladies. Medical management for multiple fibroadenomata is usually not very successful. We have observed the usage of sencroman in the dosage of 30 milligram for a period of 3 months is associated with about 30% regression of fibroadenoma. You may go through these publications to learn more about the usage of sencroman in patients with benign conditions like mastalgia and fibroadenoma. In our study, where we carried out a randomized trial in young girls below age 30 presenting with fibroadenoma, which was confirmed histologically by core needle biopsy, we found that sencroman usage for 3 months achieved significant regression in a majority of girls compared to control group. Surgical management in the form of removal of the lump is usually recommended if lady presents above the age of 30 to 35, or when there is pain associated with the lump, or if lesion is more than 5 centimeter in size, a condition called giant fibroadenoma, if there is restricted mobility of the lump, or it has ill-defined margins either on clinical examination or on imaging. A discordance between imaging findings and histopathological report is also considered an indication for surgical removal. Girls who have family history of breast or ovarian cancer should be offered removal in order to reduce the chance of a cancer being missed. Details of the indication for excision are presented in this paper published in the American Journal of Surgery. Surgery typically consists of enucleation in young girls below age 30, where we place incision closest to the lump, cut the capsule, enucleate the lesion from within the capsule and suture the overlying tissue with minimal damage to the surrounding breast tissue. Usually, we do not remove the surrounding capsule in young girls below 30, because breast tissue grows very rapidly and fills this cavity in young ladies. However, if lady is age 30 and above, where there is a chance of missing either a phylloids tumor or a frank cancer, one should resort to excision of the lump with a rim of normal tissue around it. After removal of a benign lump, it is a good practice to take the lump to a side room and request one of the colleagues to bisect this lesion and look at the features. Classically, a typical fibroadenoma on sectioning should look homogeneous white or whitish gray with no cleft-like spaces as seen here. For ladies presenting with a giant fibroadenoma measuring more than 5 centimeter in size, a special approach called Gallert-Thomas approach is described, where you approach the lesion by either an inframammary crease incision or a lateral mammary crease incision, lift the mammary gland and remove it from the posterior aspect of the breast, leaving the normal breast tissue intact. And this is how a giant fibroadenoma looked on sectioning. Again, you see uniform homogeneous grayish white appearance with no brown fluid coming out and no cleft like spaces, something that is indicative of phyllodes tumor. Other modalities recommended for treatment of fibroadenoma consists of cryoablation, where you insert a probe and cool the lesion, convert into an ice ball, which when melts results in death of cells and dissolution of the lump. This is especially useful for girls presenting with multiple fibroadenoma and may avoid multiple scars. Interstitial thermotherapy has also been recommended using laser energy. Vacuum assisted biopsy, sucking out cores of the fibroadenoma can also be carried out, removing the fibroadenoma in piecemeal. Similarly, radiofrequency ablation by radiofrequency energy has also been utilized with success. Now we come to another variety of benign lesion presenting as a discrete mass in the mammary gland called phyllodes tumor. It was first described by Mr. Muller, who called it cystosarcoma phylloides, because on sectioning he found cyst like or cleft like spaces giving a typical fern leaf like pattern, hence the name cystosarcoma phylloides. It presents in relative later period of reproductive years of life, typically in age group 30 to 40 years of life. It usually presents as large, smooth, bossylated mass with dilated, conspicuous, prominent veins with a stretched skin over it. Ulceration of the overlying skin is a rare phenomenon unless lesion is left untreated for a long time. On imaging as well as on sectioning, you will find cleft like spaces which are typically seen in phyllodes tumor and help in distinguishing it from typical fibroadenoma, which is uniformly smooth in architecture. It has well defined margins on ultrasound or mammography, and there is marked vascularity around the lesion and in the lesion due to angiogenesis. It is usually benign in majority of condition in its behavior. However, some patients may have an intermediate or borderline behavior, and about 10% of phyllodes tumor may have frankly malignant nature. It is usually aggressive in its growth pattern and is associated with a very high incidence of local recurrence if it is removed incompletely, in the range of 10 to 40% of all patients with phyllodes tumor. It rarely involves lymph nodes, only in about 2% cases or so. World Health Organization has described the following grades of phyllodes tumor. These are benign, borderline and malignant, based on these features in the stroma, the cellular atypia, stromal overgrowth, number of mitosis per 10 high power field, and the presence of tumor in the margin. Please note that majority of the phyllodes tumor you will see in practice will fall in this category of benign phyllodes. This slide emphasizes to you the recurrent nature of some phyllodes tumor if incompletely treated, like this girl presented with 5th recurrence, and she presented with a huge mass of 21 centimeter by 8 centimeter across. The principle of excision for phyllodes tumor are a wide margin of at least 2 centimeter all around the lesion, and we should also remove the skin overlying the tumor, and which will include nipple and areola and underlying pectoralis major muscle. this component of removing the overlying skin and underlying muscle help in reducing the recurrence to almost zero. On sectioning, a typical phylloid tumor presents with these cleft-like spaces and brown fluid, Coca-Cola like fluid leaks on sectioning the lesion. So, if you remove a discrete lump and section it and find these cleft-like spaces with some brown fluid coming out, you should suspect a phylloid tumor and take a tissue from the rim of the lesion, just in case if it proves to be phylloids and you have done incomplete removal, there may be a recurrence later on. Radical surgery is usually recommended for phylloid tumor in order to reduce the chance of recurrence to almost negligible. So, typically we carried out 2 centimeter margin excision with overlying skin and underlying pectoralis major muscle, leaving behind a punched out ulcer like appearance where you see the pectoralis minor muscle fibers in the tumor bed. This can be closed by approximation of the tissue by tension sutures, or if the defect is large, then you can cover it with an appropriate myocutaneous flap or even a free flap based on microvascular plastic reconstructive technique. So, some of the publications where we have found that radical surgery without axillary dissection can achieve almost a guarantee against a recurrence, and we have called it radical mastectomy sans ALND. Sans is a French word which means without. So, we do not require axillary lymph node dissection because phylloid tumor typically does not spread into lymph nodes. Adjuvant radiotherapy and chemotherapy is reserved for patients who have recurrence of the phylloid tumor or who have malignant features on final histological evaluation. In summary, benign lumps of the breast are fairly common, fibroadenoma being the commonest type of benign lump, especially in young girls. We should reassure them about the benign nature after ruling out cancer by triple assessment. If a phylloid tumor is identified, either suspected on imaging or on biopsy, you should treat it by radical surgery in order to prevent recurrence. Thank you.